Welcome to Illuminating Primary Care podcast brought to you by Menlo Park Recruitment. I'm your host, Victoria Ashton, and I'm joined by Dr Valeed Ghafoor. I worked with Valeed a few years ago, and he is now a very successful partner at a large practice in Blackpool. Hello, Valeed.
Hey, how are you, Victoria?
I'm very well. I hope you are too.
Yeah, I'm good, thank you.
Good. So me and Valeed have had many conversations, and the conversation we had a few weeks ago, I found extremely interesting, and I thought it'd be really good to share with our audience. So what we're going to be talking about today is the real impact of the investment and impact fund. But first of all, we think it's obviously important to address networks. So, could you please, Valeed, give me an overview of primary care networks, as I believe that this is where funding has been affected?
Yeah, so historically, funding has always come into primary care as in the practice directly. Um, and every now and then, NHS England has held a pot of funding which they've released in under certain circumstances. But for the last few years, I think it's the last 4 years, we've had primary care networks. So primary care networks are a new initiative that essentially group practices together based on locality, and it's focused around giving care rather than management. So, like you've had CCGs and you've had other organizations that have grouped practices in a locality, but it's more been from an organizational point of view, whereas a network is care focused. So it's very much, that network will get funded and will commission and will recruit depending on its locality. So the principle is that networks will tailor recruitment of staff to their patients' needs. And as a result, depending on the size of the network, which it is dependent on how many practices and how many patients it caters for, it will receive appropriate funding from the government. So that's networks in a nutshell. And networks have been a really interesting, really interesting topic. So some people have been very involved with networks, and some people have felt quite um, put off by the idea of networks because people have their historical commitments, like their QOF and their usual indicators, and this is all completely separate to your normal patient demand, your normal COVID pressure, your growing aging population. So people have their normal version of primary care that they've always had to deal with, and this for a lot of people feels like an extra thing, whereas some people sort of view it as an opportunity, or they view it as like an extra technique used to recruit more staff.
So, how does the investment and impact fund come in? Can you explain to me what the IIF, will abbreviate it, what that is?
Yeah. So to make that make sense, we should probably quickly touch on the fact that you have something called a DES, so a Directed Enhanced Service, which is when DESs are usually on like a nationwide scale. So it'll be the case that, primary care should offer, I don't know, let's say sexual health services, or it should offer certain services, and maybe those services are not part of your routine contract. So primary care is familiar with DESs in general, but networks have been given a DES, and it's called the Primary Care Network DES. And in keeping with that, one specific area of that is the IIF. So the DES is very centered around specific things. It's centered around access. So access meaning patients being able to get appointments easily and in a timely manner. And then the network DES has sort of stated that the IIF section of it is specific to being proactive. So it's specific to doing things that on the surface of it would just all be steps beyond what people are already doing, but everybody would probably agree they're fantastic things to do. So I'll give you an example. So learning disability checks or learning disability health reviews is something contained within QOF. It's part of what a GP should normally do. When I say GP, I mean the practice. So it's something a surgery should already do. they should have a list of patients that have learning disabilities, and then they should be touching base with them, with their carers once a year, making sure their health needs are met. And the reason for that is these people are vulnerable, so that they're at higher risk. So that's emphasized again in the IIF. So one of the criteria is learning disability assessments. So you could argue it's doing the same work. So as in, if you're doing your work for QOF, you'd be doing the IIF work anyway, which is, I think, how everybody wants it to be, and that's how it basically gives people twice as much reason to do it. So if you weren't hitting it on the QOF numbers, at least you would be hitting it on the IIF. Like it's just extra incentive, isn't it? It's extra incentive to focus on an area. Now the difficulty comes in, you would think if you're doing the same thing, it's recorded in the same way. So if I'm, or one of my team members is doing a learning disability review, we have methods to record how we do that. So we use what's called templates, and there's companies that literally make a living, having these templates available on subscription, because they're excellent at mapping out what you need to do, and then it helps staff not miss the essential things, like make sure you've done a blood test, make sure you've offered them a medication review, make sure you've asked them if they're sexually active, all these sorts of things that you would need to do in an annual review. But those codes and checks don't actually tick the boxes for IIF, and I'm using that phrase deliberately when I say tick the boxes, because you have done the work. So as in, the whole purpose was to do a review, and you've done the review. But then if you've not hit a minimum target, then it classes it as if you haven't done it altogether. So I'll give you an example. Let's say the minimum target is 60%. So if you have 100 patients, it means 60 of them should have had that review and should have been coded in the way the IIF wants. Now, if you've done 50%, but the chances are most of them are going to get reviewed regardless, because you would have done that for QOF anyway, if you weren't doing it as you go along. And I'll talk through what that means in just a sec, but let's say you've done your QOF, so you've physically seen your patients, you've done everything you needed to do, but you haven't recorded it in the way the IIF needed, then you would receive none of that funding.
So you've done the work, the patients are satisfied, they're safe. You've done the QOF side of things, but because you've not recorded it a certain way for the IIF, that's it, you lose all the funding.
Yeah. So you don't receive any of it for that point. So let's say, for example, it's worth 30 points. Okay.
Yeah.
Each point is worth something like £200 roughly. So 200 times 30, what is that, 6,000?
Yeah.
I think so.
I put me on the spot there, Valeed.
So I'm guessing myself, but
Yeah.
so that for example would be 6K of funding you've lost straight away for work that you've actually done. And there's a couple of things to be aware of, because a lot of this sounds like finance or money grabbing, but it's not, because the point is, the way healthcare is supposed to work is you're supposed to see a patient, and then depending on what that patient has, you're supposed to code the appropriate things. So for example, that person might come to you with a chest infection, but they've got a learning disability. So you deal with the chest infection, and then you recognize, this person has a learning disability. So while they're there, you'd probably say to them, how have you been otherwise? Are you sexually active? Have you had a blood test recently? Do you mind if I also check your blood pressure? So you'd be taking the opportunity to think, this is a vulnerable person. They didn't come for this, but since they're here, let's get other stuff done.
Yeah.
And then if towards the end of the year, all of the people on that register have not been seen, then obviously they either haven't felt the need to be seen, or they've come in and the person's been distracted by what they've come in with and not focused on the general health, which is easily done. If you come in with an ankle sprain, you might not talk about someone's general health. You might just focus on the ankle sprain, because obviously pressures are tense. So then you would make a specific effort to bring in those that you haven't seen, because you'd be thinking, hang on, there's 50 people here that ideally we should have seen in the last 12 months and we haven't. So let's get them in, and let's get them in and see them. So that's the reason the registers are important, because if somebody doesn't naturally come your way, you can specifically then search for them. And if you're doing all that work and then actually you're not getting funding because there's different letters and numbers that should have been put into the machine, um, which you'd think is easy, but it's not. It's not like we use this phrase in our practice. We wish everything was like IKEA furniture. When you get IKEA furniture, you get the instructions with it, don't you? And it says these are the pieces. Make sure you've got the pieces. These are the steps to assemble the furniture. It's not like that in healthcare. A funding criteria will be created, and you'll be told about that funding criteria after it's been implemented. It's not like somebody says in 6 months' time, IIF's going to be here. Here are going to be the parameters that you are going to need to use, and these are the codes you will need to record, because then you'd actually have time to prepare. No, what will happen is there'll be a government announcement, 2 weeks from now, this new fund is being created. And then what is that fund? We don't know. We'll tell you closer to the time. The fund will come into place. You'll then be 3 months down the line, and someone will say, "Oh, did you not get this email telling you about the codes you should be using?" And you're 3 months into the financial year. So it's that thing of, because it makes us sound very incompetent when I talk about the way I am, but it's not our fault. As in, if somebody actually said, "Here's your blueprint for the next 12 months. Here are the codes you're going to need to use. Here's the way to get organized," then we could sit down and plan it. Um, but often things, as you'll be aware, with contract changes and everything else, get changed at very short notice, and we often don't have the intricacies or the details of what to do.
Why can't I don't know if anybody's proposed this, but to me, this seems like a lot of extra work, unnecessary extra work when you're doing the same job. If you're hitting QOF's targets and they're happy with you, why can't the IIF work in conjunction with QOF and you just have the one system to record everything and then nothing gets missed and no practices are going without what's essentially really important funding for the work that they do? Why can't that be done?
I honestly, it. I mean, the thing I'd say to you is it almost makes too much sense. So nothing seems to nothing seems to be done in a simple way in healthcare, and I can understand if it is a different target. So, for example, I can understand if it's something to do with flu jabs given within a certain age range, then that's not the same as give everyone a flu jab, because then you talk an age range is different.
Mm.
But with the stuff I'm talking about for IIF, it's literally the same. It's literally has had an annual check. So as in like I'm talking about where it's relevant. It would be really helpful if it was the same coding, because
Right.
because otherwise it's not. You see, so the thing is, it's still doable, but firstly, somebody has to look through the 107-page document that is the IIF document, and go through every single parameter, every single point, reference every single code, then has to check every single patient on every relevant register. Like that's a
Who has time for that in
Exactly.
primary care?
That's a ridiculous amount of work.
Yeah.
Not only that, the sheer new training that you would have to give to your staff members to say, you've always done it this way, and this has always been fine. But by the way, here are all the things that we now need you to also include all of these things for. And it's literally an admin exercise, isn't it? It's because they're doing the same thing they've always done.
Mm.
They've always done their learning disability reviews. They've always done it in the interest of the patient. The actual things you're doing are the same. So you're basically just giving them. We always say, it's death by paperwork. It's just this thing of you've got extra admin duties, extra responsibilities, and that aspect of the job doesn't come with any funding. It's not like you get an extra member of the admin team who can take charge of the IIF. Our funding in primary care is actually shrinking year on year. So we have a shrinking funding stream and an increased demand on staff, which is why so much of the staff are burning out. So it's things like this that people aren't really aware of.
So obviously this coding side of things seems a little ridiculous, especially if it's exactly the same thing that you'd be doing with QOF. And I'm sure there's good intentions in place with the IIF, but is the coding side the only concern, the only issue, or is there anything else that's going on within the IIF that are causing practice difficulties when it comes to funding?
Yeah, several things really. So some of this is up for debate, and some of this is almost established. Um, the first thing is the IIF funding is for the network, right? So, as in those funds come to the network, not to the practices. So, most people, and I say most people loosely because it's not like I've spoke to most GPs, but from my experience, the majority of GPs I know will want to use staff from the network to do the IIF work because that money's going to go back into the network. It's not going to benefit the practice. So you don't. It's not really a smart thing to do to use your personal staff that you pay for separate to the network. So, as in, you personally fund your personal staff, and then they are not doing their usual work, which is consulting patients, doing medication reviews. Take a pharmacist, for example, right? So, this pharmacist would not be speaking to his normal hypertensive patients. He would not be doing medication reviews. He would not be reviewing prescription requests. Instead, he would be dealing with some sort of medication related target on the IIF list. So, one, that's going to reduce your patient consultations. So, you're going to lose the number of available pharmacy appointments, which obviously your patients are not going to be happy about. And the funding that comes in from that isn't even going to give you the ability to replace that person with somebody else for the practice because it's going to the network. So, and the network money isn't your money. The network money is a collective pot. And that collective pot has to work for the collective. So if you turn around to the collective and you say, well, I used my personal staff members to do this IIF work, they're going to say, well, why didn't you just use the network staff to do it? You know, their salaries are funded through this income. So that's the general approach of people. The problem with that is when it's our pot, we can do whatever we want with it. So in our surgery, we could say, our surgery struggles to recruit doctors. We need lots of pharmacists and ACPs to help us with the clinical work. Right? We're in a geographically difficult area to recruit. We need lots of allied health professionals to help us with our role in seeing patients. Now, another area in like a big city, London, Manchester, Leeds, where there are potentially lots more doctors, they might not struggle as much. They still will struggle because there's a recruitment issue across the country, but they might not struggle as much. So they might say, right, so our personal funding, we actually want to prioritize having, I don't know, less practice nurses. We need more practice nurses. We've got enough doctors. We need more practice nurses. So they can do that. Now, with network funding, you don't have that choice. So the staff you can recruit is dictated to you. So you're told you have this selection of staff members that you can recruit from, which does not include practice nurses, which does not include doctors,
That's
and
crazy.
and up until this April didn't include ANPs.
Th-
So very like so none of the staff that we usually would depend on you could use. And they also put a restriction on the rate you can pay the staff in terms of what you can be funded for the role. And that funding is in nearly every case inferior to what that person would get elsewhere. So so then it's also a difficult position to fill because people are, I'll give you an example. I can't remember off the top of my head. I think the pharmacist rate's like £44 or something an hour, something like that. But they're making more than that working in the community. They're working just doing what for them is comfortable work in the community. They would get paid that or more. So if you want a prescribing pharmacist, you're never going to get that at that sort of rate. What you will get is a brand new pharmacist fresh out of uni who is interested in seeing what primary care is about, who needs a lot of training, a lot of supervision, a lot of mentoring, and will almost need you to explain every role that you're giving to them. So typically, you get relatively junior members of staff who need lots of training, advice, and guidance and supervision, which you put out for. Well, I'll give you one clear example. We had an advert out for a mental health worker for 2.5 years. I think 2.5 years, and one was recruited recently, and they didn't feel so. It was like a job share between the hospital and the network, and the hospital was supposed to provide the mentoring, and we were supposed to provide the on-site supervision, like a dual-funded role. And they didn't feel that the trust was supporting them, and they've given their resignation in.
And that took you 2 years to get that individual,
That took us two
and
years.
and and then they didn't stay. So let me just recap on this. So the the IAF dictate who you're allowed to recruit. They dictate how much you're allowed to pay them, and it doesn't include practice nurses and GPs, which are in massive demand everywhere. And he said recently AMPs have been added to that, though, which thank goodness for that. So let's say in your practice, you don't need the staff that they're saying you're allowed to recruit. So you don't invest that money into those staff. What happens?
So it would be unusual if you didn't need any of them, because there's a broad variety of what's offered. So you can have like podiatrists, first contact practitioners, which are physios, paramedics, but you might already have had like a home visiting team set up in your area. So you might think, well, actually, I don't need a paramedic, or you might have already employed a physio. So you might think, you might have been very forward planning. People before COVID had mental health workers, physios, pharmacists in their practices. So you might have already been ahead of the curve, and you might have not really needed those roles. But to answer your question, if you don't use the funding that is allocated to your PCN, they basically say, well, it looks like you don't need it, so we just won't give it to you next year. Um,
And even though the following year you could have a real need for the clinicians that they're enabling you to recruit, that's it. Tough. You didn't use it last year, so you're not having it this year.
yeah, essentially.
That's just crazy. But
From your
primary care is evolving so much. How can you deny a practice funding if the circumstances have changed? And let's face it, especially since COVID, circumstances have changed immensely, haven't they? And they continue to do so. So that just seems ridiculous. Okay, you don't use it that year, you've lost it. But don't deny them the option to use it the following year. That's just, I said it before, crazy. It
Yeah.
is. So I know that you've done a lot of work within your practice to address these issues, and quite well from what I understand. Obviously, there's probably going to be a lot of practices out there that can relate to this conversation, the things that you're bringing to light here. Is there a way you could propose? Is there any suggestions you would have for them to help alleviate this and avoid issues with the IIF?
Yeah, so there's two bits there. So one is the bit about network staffing. So you in an ideal world, you'd have something like a skill matrix where you would look at across your network what services and skills do your clinicians and colleagues have, and you would look at where the natural gaps are. So for example, maybe you've got lots of clinical staff, you've got lots of paramedics and ANPs and GPs, but what you're really, really lacking on is the medication side of things. So you're really lacking on people that can do med reviews, structured medication reviews. There's a lot of things on the IIF about like sort of continuity and recyclable energy and sort of being green, basically. So things like switching inhalers over to carbon-free inhalers because it's better for the environment, and there's funding attached to that. So people obviously you want to, so they want you to do it. So the sort of medication-driven things are going to be best done by pharmacists, naturally, because they're medication specialists. So then as a network, you might say, we should prioritize getting pharmacists. We should prioritize that so it can help us do our IAF work. So it can help us hit. So you've got the DES, which is the overarching thing, which is everything. That's like online access, it's total triage, it's care home care, and a bit of that is IIF. But the IIF is the bit that it's sort of the hardest to get, which is why people talk about the IIF, even though it's one portion of it. Because the issue is, let's say your inhaler target for green energy is 60%, right? And let's say one of your pharmacists goes off sick, and some of them are busy with QOF and some of them are busy with patient consultations, but all year they've switched 50% of your patients to the sort of green alternative. Now, if you don't hit the minimum threshold of 60%, you get nothing. So it's that thing of, so basically the thing, and this isn't how it should be, but what people are having to do is they're having to look at the targets. They're having to say, right, is this actually achievable? This target of 70% minimum, are we really going to be able to do this? Because if we're not, let's just forget the whole thing. What, and that's not how it should be. It should be like QOF, for example. You get funded according to what you do. So the better you do, the better funded it is. But it's really it's really it's really upsetting when you can't recruit for a position because the rate you can offer is capped, and then the thing you want to use them for is so hard to achieve. That's why people talk about IIF, because it's so difficult to do well. Like, for example, one of the targets on IIF, actually this year now, they actually wanted to put it in place last year, but I think they got so much kickback they deferred it for a year, which was all patients should be seen within 2 weeks. So we were like, what the heck happens to your 4 to 6 week like normal reviews? You start a medication, you tell a patient, I want to see you in 6 weeks. I want to see you in 4 weeks. That's supposed to be continuity of care. It's supposed to be chronic condition management. That's what primary care is all about. Whereas it's sort of forcing you to become this more acute service, is forcing you to become more short-term need rather than long-term care. Why wasn't it instead more than 50% of your patients should have access to appointments in 4 to 6 weeks down the line, so that they're not going to A&E, so that they're not going to the walk-in centre? Why not insist that we offer chronic follow-up appointments instead of saying no, offer them appointments now? So that isn't going to be sustainable. Like, who the heck's going to be able to offer that? Most people can barely offer 4 week appointments. They're so far behind and they're so short staffed. So how many surgeries are going to say, yep, I think we'll manage that to a high percentage successfully? And if they did, at what cost? If you're able to offer those appointments within 2 weeks, you probably have had to cut a lot of your long-term follow-up appointments, because those appointments need to come from somewhere. Each person can only see so many patients. So it's these. So the things on IIF some of them are very straightforward, like the learning disability thing, and I absolutely agree with it, and we do it anyway, right? I absolutely agree with it. Flu vaccines, I agree with. We do them anyway. People should be getting flu vaccines. It's pushed heavily nationally. I get all of that. And then you've got some things where we're switching people to green inhalers. Okay, you can argue that's good for the environment. Fine. I'm not sure it's the best use of time for highly skilled members of the team, like pharmacists. I wonder if they could be doing more productive things with their time.
Mm.
And then you have things like see everyone within 2 weeks, and you're like, what the heck do I do with this? Do I just ignore this altogether, or do we genuinely try to do this? And if we do try to do it, what do we sacrifice? Because the system is stretched, the appointments are limited. Do we give up 4-week review appointments, do we just no longer offer them? Or do we only offer them for very serious conditions? These are the sort of stresses these conversations create in practices. And obviously, having demand, COVID, and reduced general funding, then restricted network funding, then what a lot of people feel like are almost unrealistic, unachievable IIF targets, it feels quite overwhelming.
Mm. It
Um,
sounds it.
yeah, and that's why, when people talk about GPs burning out, primary care burning out, this is why. It's not one thing. It's not, my pay packet hasn't increased in a year and a half. That's not the problem. The problem is the other 105 things that are going wrong. And then it's everyone's individual coping point. For you, the 20th thing might be the thing that does it for you. For another person, it might be the 105th thing that does it for them. But everyone's got a breaking point. And the question is, how do you prioritize where to spend your attention? For IIF, what's going to cause the practices the least amount of stress while still providing good care for patients, while realistically being able to achieve some targets. That's the difficult conversation.
What have you done in your practice, Valeed?
So we are in a very unique position because in Blackpool there's a massive GP shortage, even compared to nationally. So obviously wherever you've got sort of, golden hello and golden handshake type schemes to give funding for people to join, they're particularly difficult to recruit in, and Blackpool's one of them areas. So Blackpool has always had, or not always had, compared to other areas in the country, it's been more willing to accept allied health professionals in the workforce. So, for example, my practice, the number of pharmacists and ACPs far outweigh the number of GPs. So, most of our workforce is non-medical, is non-doctors. So, we're relatively confident knowing what people's boundaries are and knowing what people can do confidently and what they can't do confidently. So we actually, and I'm not advising everyone else do this, but we give some of the more complex medication work, even if it's for the IIF, we use our practice staff to do some of it because it might be more complicated, or they might be able to do a lot of it in a small space of time, so it's efficient for them to do it. And then if the role that they were going to do is perhaps relatively simpler, like maybe it's a routine high blood pressure medication review, then that instead might get done by our practice nurse. Or if we've got a more junior pharmacist in training, perhaps from the network, they would still be able to do a medication review. So we might give that work to them instead. So we're trying to use the sort of unique strengths of individuals, regardless of which domain they're working in. And overall, it works out. So, like, it might be that the network IIF stuff is done by the practice pharmacist, but then the network pharmacist might do something for the practice, which isn't technically how most people would probably use them, but that works for us.
Yeah, but obviously not everybody's got the luxury of such a great clinical support team.
Yeah.
You've got your smaller practices with a handful of staff, and it's going to prove quite difficult for them. You did mention earlier on that the network have staff that can help with this, but how does that work? Does the practice contact the network and go, "We need X, Y, and Z doing"?
So,
Um,
so most networks are probably between 2 and 4 practices. Um, the more practices you have, the less amount of time that member of staff will spend in your practice. So if it's a paramedic and let's say there are 5 practices in your network, if they're all roughly the same size, because it's not dependent on practices, it's dependent on how many patients your practice has, because your need comes from your patient list size. If you've got 5 practices and one of them is only 10% of the size of the other 4, then obviously you'd assume that one practice has a far lower need than all the other practices because there's less patients there. So if you have 5 practices and they're all even patient numbers, then that paramedic on average would do 1 day at each practice. Now, if that paramedic's job, so this is now the very tricky bit. So that would be the technical allocation of the paramedic. If And most networks have fairly senior clinicians leading them because they're usually into management, which is why they're bothering to be involved in the network in the first place. So most of them would think a little bit more sensibly, and they'd say, well, hang on, this paramedic's job is to, let's say, in this area, do home visits. Let's say that's why they've got the paramedic, right? It's not why everybody uses them, but let's just assume that's why they're being used. It would make more sense to say, right, this paramedic works across the 5 sites every day. So so let's say geographically it's like a couple of miles between the surgeries and it's not that far. Then you say, right, so this paramedic maybe works out of a central building where they've got somebody they can speak to, get advice from, and all day for the 5 days, requests come in for visits and they go and do the visits. So that way, the practices have cover all days of the week rather than one practice having lots of cover on one day and no cover on the rest. That would be a practical solution. But that comes down to individual networks, that comes down to their preferences. Some practices are very, no, I want my person for one day to do my stuff. And that's the difficulty in professional working, because let's say if your network is only 2 practices and you have polar opposite ways of working, right? Let's say one of you is entirely doctor focused and one of you is entirely allied health professional focused. It goes to say that your outlook and your approach is probably going to be entirely different. So it might be that you can't have a combined role for that paramedic. That paramedic would probably be doing very different things for both practices, which then makes it hard for the paramedic because they don't have the same job spec necessarily. They have different roles and responsibilities, and that can be very confusing, especially if you are a junior member of the team.
So tapping into the network's staff could be quite tricky as well, because not only have they got their own duties, but if you are part of a larger network with quite a large number of practices, then I would imagine that the work that needs to be conducted to satisfy the IIF needs more than maybe one person a week, one day a week coming in and helping a practice. So this
Yeah,
obviously shows me why practices are having to use their own staff and
yeah,
take them away from the jobs that need doing in practice to satisfy the needs of the IIF. It's a bit of a vicious circle, isn't it?
yeah. So there's 2 things for that. So firstly, you're right, and if that money comes into the network, it doesn't really benefit the practice. So it's not like, so when the practice gives up its staff member to do IIF work, that practice doesn't benefit from that, because it's not like the network money is for the practice, it's for the network. So if the network gets money, it can use it to recruit another staff member, which so it's not like you might get the benefit indirectly. So you might have given up your staff member's time to raise money for the network. Maybe that then lets you get a paramedic, which helps you with your home visits, but it's not going to be related to the pharmacist time that you lost. So that's one thing to consider. The second thing is, again, it comes down to how much time planning and how forward thinking network directors are. But you could, in theory, have a designated space or even a virtual space where you say this is a network, I don't know, hub or something. For some reason, I was going to say command center. I don't know why. I think that says more about me than anything
Very,
else. But
very militant.
yeah, so you've got like this network hub, and let's say you have forward vision and you say, right, I've seen the IIF for next year. I've seen these are like, 50% of the IIF is due to medication related things. So for the prospective year, I want to focus on recruiting pharmacists and pharmacy technicians in a larger proportion than other members of the team, because maybe we've already got lots of clinicians, for example. So then you set up a system, and you're like, right, so the pharmacy techs need to do this, and the pharmacists need to do this, and here are your deadlines, and these are your different work streams. And if you've mapped it out, and those people are doing it for the whole network, then you'd probably absolutely smash your IAF targets across the board. But that would need everyone to be on board. It would need everyone to agree on the role that you're employing. It would need someone to sit down and map out the whole process. And generally, people are struggling with time. So it's but that's the way I see it working really well. I see it working well in that second analogy of the paramedic, where the paramedic covers all the surgeries and has support and advice. And then perhaps you say, this is the approach we're going to take. One's probably not enough. Why don't we get two? Why don't we get two paramedics? And between them, they should be able to cover the five. And the benefit of that is then if your GPs are not having to go and do home visits, then they've got more time to see patients, or they've got more time to sign their medications, or they've got more time to get to think about how to plan a network. Like they've got the brain space to do stuff that's good for the practice.
Yeah.
Because if all you're doing is bang, 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 and all you're doing is the work, then you never have time to think about anything else.
Thank you, Valeed. This has been a really, really interesting subject to cover, and one that I'm sure will resonate with a lot of primary care providers across the country. Um, Myself and Dr. Ghafoor, Valeed, I do call him Valeed a lot. I do speak to him a lot. We'll be doing another podcast. The next podcast will be how to help newly qualified GPs better understand earnings, the differences between locum earnings, salaried earnings, and how partnership earnings work. So we do hope that you'll join us, and we will be notifying you all when that will be taking place once the date has been finalised. Once again, Valeed, I want to thank you so much for your time today. It's been an absolute pleasure, and definitely an eye opener for myself and maybe a few others that are not in the know about the IIF. So you enjoy the rest of your day, and I look forward to when we speak again soon. You take care.
You too. It was a pleasure, and thank you for having me.